Lymphedema is defined as a chronic, persistent accumulation of tissue fluid and protein, most often in the extremities, that's caused by either abnormal development or injury to the lymphatic system. Patients with lymphedema may experience a variety of symptoms that can range anywhere from very mild to severe swelling, limb heaviness or fatigue, pitting, skin thickening, inability to wear certain clothing or jewelry, and chronic recurrent infections within the affected limb. As a general rule of thumb, it's important to identify high-risk patients early on in their disease course, or even before symptoms become clinically apparent, when intervention offers the greatest opportunity to limit or reverse the progression of the disease. Such patients should be referred to a lymphedema specialist for baseline assessment and high-risk surveillance in order to identify changes in the lymphatic system at the earliest possible stage. In general, the treatment of lymphedema is a multidisciplinary effort that's tailored to each individual's unique presentation and consists of both non-operative and operative interventions aimed at optimizing limb volume reduction, improving functionality and quality of life, decreasing infection risk, and in some cases, minimizing the burden of compression garment use. At the foundation of all treatment pathways is complex decongestive therapy, or CDT, which utilizes various forms of compression therapy under the supervision of a certified lymphedema therapist to first optimize and then maintain limb volume reductions. This period of prehabilitation is extremely important for determining which patients are most likely to benefit from surgical intervention. In some early cases of lymphedema, CDT alone is sufficient to normalize limb volume and permit eventual weaning of compression therapy or garments over time. However, for patients who demonstrate persistent signs and symptoms of lymphedema or who develop infections despite optimal conservative therapy, surgical intervention may be warranted. Options for surgical treatment of lymphedema can be broadly divided into two general categories. There are reconstructive or physiologic procedures such as lymphovenous bypass and vascularized lymph node transfer, which aim to restore or improve lymphatic drainage from the limb. And there are reductive procedures such as suction-assisted lipectomy or excisional debulking, which aim to maximally reduce limb volume through the physical removal of diseased tissue. Although there are good data supporting the efficacy of lymphovenous bypass and vascularized lymph node transfer, these procedures will not work in patients whose swelling is dominated by fibrofatty tissue accumulation. In these cases specifically, only reductive procedures such as liposuction and or direct excision of the diseased tissue can effectively reduce limb volume. In patients who present with mixed-phase lymphedema, stage liposuction can be effectively combined with physiologic procedures to achieve a more complete volume reduction over time. Recovery after surgery is largely dependent on the type of operation performed. Patients who undergo lymphovenous bypass or vascularized lymph node transfer typically require a 2 to 4 week period of activity restrictions. In most cases, physical therapy and compression are resumed within 2 weeks, and patients are instructed to continue compression garment use for at least 6 months after surgery to help aid healing and recovery of lymphatic function. It's important to note that while minimizing the burden of compression therapy is a goal of lymphedema treatment, many patients will still require at least some form of intermittent or temporary compression garment use for life. For patients undergoing suction-assisted lipectomy, compression garment use is considered a lifelong component of treatment and serves to maintain the results achieved by liposuction, as well as minimize the development of recurrent edema over time.